Dr. Bhattacharya will give me a warning that your screen is not visible.
Okay, sir.
See,
Yes.
my presentation is, first part of presentation is at emergency snake bite. Snake bite when comes to an emergency. Practically, we have seen in our observation for last 15 years that most of the interns passing from the city medical colleges are not exposed to primary care treatment of snake bites. They get referred cases only. That's why I am giving emphasis on the emergency management of snake bite now. We have one single page protocol for our state of West Bengal. This was prepared in the year 2012 and distributed to all the bedded health centers and second-tier hospitals of West Bengal. What is written over here? You see the middle part of the protocol. You see there is a flow chart. What is written over here? Patient attending emergency room of any hospital, history of bite, snake or unknown. I also tell suspected bite. All these cases must be admitted. All these cases must be admitted for observation. Patient may refuse admission, but we must write and we must impose that you must be admitted for 24 hours. Before admission in the emergency, we will see for any crisis. What may be the crisis? The patient may reach you in a state of cardiac arrest, in a state of no respiration, total respiratory arrest. You see, here I have written, if the patient has come in cardiac arrest, you will have to give CPR, cardiopulmonary resuscitation. And if the patient is in total respiratory arrest, you will have to start Ambu Bag ventilation. When we used to tell that in the emergency, you will have to start Ambu Bag ventilation, some of my friends used to smile and they used to criticize us that you have made this protocol in the comfort of an AC room of the Swasthya Bhavan or in the ICMR. It's not possible, but it's possible. It's quite possible. My junior friend, Dr. Alam has proved it. You see, here Dr. Alam, he had intubated and started Ambu Bag ventilation. Please mute your mic. Please mute your mic. Everybody kindly mute your mic. Otherwise, I will have to stop my presentation. 100% mic must be muted. My junior friend, Dr. Alam has proved it. In the year 2017, when he was posted in a block primary health center of West Midnapur district of West Bengal, that is Halboni Health Center, he had intubated this 10-year boy of common Krait-Bite. This boy presented with respiratory arrest. Dr. Alam intubated this boy and started Ambu Bag ventilation. Then we had tried our best for an I2 bed at Midnapur Medical College, 20 kilometers away, but I2 bed was not available. Dr. Alam kept this boy in Ambu Bag ventilation only for 5.5 hours. Then this boy was revived and his respiration returned, spontaneous respiration returned. It's not an exception. It's not an exception, not at all an exception. If you have no training for endotracheal intubation, usually endotracheal intubation is done by anesthesiologist, but Dr. Alam is not at all an anesthesiologist. If you cannot do endotracheal intubation, you can do an LMA insertion, laryngeal mask array. I will request all the CMOHs and all administrative officers to provide laryngeal mask arrays to the primary care hospitals. After the path shown by Dr. Alam, many people have done this in primary care hospitals. You see here, Dr. Madhusudan Hemram of Onda Super Speciality Hospital is being felicitated by then CMH Dr. Prasun Kumar Das for his historical work. This 3.5-year-old boy was bitten by a cobra, and Dr. Hemram got this boy in total respiratory failure state. Dr. Hemram intubated this little boy and started Ambu Bag ventilation. He communicated with his friend at Bankura Medical College to keep a pediatric ICU bed ready for this boy. And Dr. Hemram himself carried this boy in an ambulance to Bankura Medical College. He put this boy in the ICU bed and started mechanical ventilation only. Then he returned to Onda. This thing was done recently by medical officers of Borjora State General Hospital of Bankura again. Here, the medical officers of Borjora Hospital, they intubated this pregnant lady with snake bite. They trained the relative of this patient how to maintain Ambu Bag ventilation. And this patient was carried to Bankura Medical College 26 years away from Borjora Hospital by Ambu Bag ventilation, kept Ambu Bag ventilation by relative of the patient only. You see, these trainee sisters of Jongipur SD Hospital of Murshidabad district of West Bengal, they kept this little boy in artificial ventilation by Ambu Bag only for 18 hours. So it's not impracticable. It's not at all impracticable. If you have will, you can do it. After I have admitted one patient from the emergency, I have to start a normal saline, slow drip. I have to start a normal saline in slow drip. Whenever I have got any one sign or symptom sure to be systemic envenomation, that is when I am sure that the patient has been envenomated, I will ask on duty sister to charge 10 vials of polyvalent antivenom into the running bottle. 10 vials, 100 milliliter of polyvalent antivenom charged into the running bottle, and this bottle is then in jet. The fluid will go in jet. We have started popularizing one rule of 100. What is rule of 100? If you can infuse 100 milliliter of antivenom within 100 minutes of bite, you are 100% sure that your patient will be cured. Infuse 100 milliliter of antivenom within 100 milliliter of bite, within 100 minutes of bite, you will be 100% sure that the patient will survive. So when you are treating a primary emergency patient of primary snake bite, start in jet. IV fluid mixed with antivenom will have to be started in jet. Our target will be to complete this bottle within 100 minutes. You see, here we have written 0.25 milliliter of adrenaline subcutaneously before antivenom. This is pre-medication. If there is any absolute contraindication like old age, history of CBA, history of hypertension, very little boy, then you can avoid this pre-medication. But in other cases, you can give 0.25 milliliter of adrenaline subcutaneously before giving antivenom infusion. How you will be sure that this patient is envenomated or not? What are the signs and symptoms of envenomation? In Cobra Bite, this is very vivid. In Cobra Bite, there will be no doubt. There will be visible bite marks and severe pain. Visible bite marks and severe pain. We have some clarification to be given for bite marks. Practically, bite marks don't give any clue to amount or at all there is envenomation or not. Looking towards bite mark, you cannot comment that there is envenomation or not. In common Krait-Bite, there will be no bite mark. In common Krait-Bite, there will be no bite mark. But in Cobra Bite, usually there will be 2 bite marks like this. You see the index finger of this man, there are 2 bite marks, classical bite marks. Classical bite marks are seen only in hooded snake bites, cobra bites, but it's not sure that there will be 2 bite marks. What about this bite mark on the foot? This is also a cobra bite mark. You see, it is looking like a incised wound, but it was certainly a case of cobra bite, common monocled cobra bite. So if you stick to the 2 bite mark, then you will miss this bite mark. Don't stick to the dictum that 2 bite mark is for venomous bite. Venomous bite may be without any bite mark, single bite mark, multiple bite mark, scratch mark, incised wound like this, but there will be severe pain in cobra bite. There will be painful bite. There will be painful bite and progressive swelling. These are the hallmarks to diagnose envenomation in a case of hooded snake bite. Cobra snake bites are diagnosed by local signs only: painful bite and progressive swelling. You see, this hand is swollen within half an hour, discolored, there is ecchymosis. You see, there is blister formation and the hand is swollen. There will be swelling and severe pain. In the stage of swelling and severe pain, you start antivenom in case of cobra bite. How to diagnose a case of viper bite, Russell's viper bite? Russell's viper bites are diagnosed by hemotoxic features, abnormal bleeding from any orifice. You see here, bleeding from gum. The bleeding from gum has made his tongue red. Bleeding from nose, bleeding from bite mark. You see the leg, bleeding from bite mark has come down below the sole also. In case of doubt, whether there is envenomation or not in hemotoxic bite, you have to do a 20 WBCT, 20-minute whole blood clotting test. This is a very simple bedside test. You have to use one plain and simple glass test tube. I am giving emphasis on this plain and simple 5 rupee glass test tube, not costly one, not Borosil, nothing else. Test tubes used in the laboratories of high schools only. Glass test tube, you have to use a clean, dry and chemical-free new glass test tube. These glass test tubes costs only 5 rupees. Draw 2-3 milliliter of venous blood and keep it undisturbed for 20 minutes. Keep in mind, the test is called 20 WBCT, 20-minute whole blood clotting test. You need not take the reading at 10 minutes or 5 minutes or 15 minutes or 19 minutes. You have to take the reading at dot at 20 minutes. Just day before yesterday, someone had sent me on video and he asked me whether this 20 WBCT is positive after 1 hour. So funny. Can you ask me, in a T20 cricket match, how much run is scored in 60 overs? Like this. You have to take the reading dot at 20 minutes. Gently tilt, not sec. Gently tilt the test tube. If the blood in the test tube is not clotted, then it is sure that hemotoxic envenomation is there. Sometimes in hemotoxic envenomation, viper bite, the patient may miss. Whether you will diagnose envenomation looking towards the bite mark? No. Bite marks are of no use. Bite marks are of no use. You see, so deep and classical 2 bite marks in the foot of this girl. Practically, this girl turned towards a dry bite. The girl turned to be a case of dry bite. She was admitted by me in Kolkata National Medical College in the early morning. She was kept admitted for 24 hours. We had done 20 WBCT for 5 times. till the evening, every time blood was clotted. So if you diagnose this to be a case of venomous bite, just looking towards the bite mark, you will overtreat the patient. Don't do that. In case of cobra bite, there will be no bite marks in 99% of cases. Even multiple bite marks may be venomous bite. Can we start antivenom looking towards the snake brought along with the patient? No. Many times a wrong snake was brought to the hospital. You see this snake? Later on, I will show you how to detect, how to identify a venomous snake. This is a purely non-venomous snake, wolf snake. In Bengali, it's called a ghorchiti. This ghorchiti or wolf snake was brought along with a snake bite patient, 10 years girl. She was brought to Chandrakona Health Center of West Midnapur. But Dr. Subhajit Pal got not clotted blood twice. On admission, the blood was not clotting. She asked us whether this snake is a venomous one. Each and everybody of our WhatsApp group were of opinion that this snake is not a venomous one. It's a non-venomous wolf snake. But Dr. Pal was repeatedly telling, I am getting not clotted blood. The girl was complaining of pain and there was swelling. Practically, it was a case of Russell's viper bite. The snake has bitten her and run away. And her relatives got this innocent snake and killed it and brought it to the hospital. If you look to this snake brought to the hospital, you can miss a venomous bite. We have told you that you have admitted the patient and you have started a plain drip, and whenever you have got any sign or symptom of envenomation, you have asked the sister to charge 10 vials of antivenom into the running bottle. Some old people, including some senior nurses, will impose you to do a skin test. No skin test is needed. In the WHO SERO guideline 2010, in the year 2010, WHO SERO guideline has clearly mentioned that no skin test is required for antivenom infusion. Skin test is of no value. Most of the time they are false negative. And you have to infuse antivenom. It's a life-saving drug. Why should I go for skin test and wait for a few time? How can we diagnose that antivenom reaction is there? After infusion of antivenom, you may get some adverse reactions. Usually, arterial rashes and scalp itchings are common adverse reactions. These are mild reactions. In 80% of cases, there will be arterial rashes and scalp itching only. There may be sudden fall of BP. The patient may go to shock. The patient may vomit. The patient may complain of pain abdomen or respiratory distress. There may be bronchospasm. Very rarely there will be severe reaction like angioedema. Whatever may be the reaction, maybe just arterial rashes, maybe fall of BP, maybe bronchospasm. Stop the fluid, stop the running fluid and give 0.5 milliliter of adrenaline intramuscularly. Here you are giving intramuscularly. I use one dictum to keep it in mind. When you have admitted a patient of snake bite, it's a serious patient. You are treating a serious patient. Again, the patient, after getting some amount of antivenom, the patient is showing antivenom reaction. You are in double serious condition. You are treating a very serious patient. Keep in mind, I am treating a very serious patient. When there is reaction, keep in mind that I am treating a very serious patient. I am. So, adrenaline will be given IM, intramuscular. I am treating a serious patient, so adrenaline will be given intramuscularly. To treat a reaction, don't give subcutaneous. You have given subcutaneously for prevention as pre-medication, but you have the IV channel open. So you may be tempted to give it intravenously. Never, never. Don't give intravenous adrenaline. Intravenous adrenaline will result in tachyarrhythmia. Very serious arrhythmias may come after intravenous infusion of adrenaline. So never give adrenaline intravenously. Here we are showing 10 vials of polyvalent antivenom and some other drugs. You see some ampoules, small ampoules are here. What are those drugs? An injection can save a Cobra Bite patient. Keep in mind, an injection can save a Cobra Bite patient. What is an injection? You see in the picture, 1 ampoule atropine and 3 ampoule neostigmine. Atropine and neostigmine. I am showing you here 4 injections, 1 ampoule atropine and 3 neostigmine. But I have written over here an injection. Why I have done this grammatical mistake? I have done it intentionally. An means atropine, then neostigmine. If you reverse it, Na not available, the patient may die. A Cobra Bite patient may die instead of 18 vials of antivenom or 20 vials of antivenom. All these unfortunate young lady and young men died after 18 vials and 20 vials of antivenom because atropine and neostigmine was Na, not available. Always be sure that your hospital have a stock of neostigmine injection. It is a very low cost drug. 1 vial of polyvalent antivenom costs nearly 600 rupees. You are infusing 10 vials, 6,000 rupees. But 1 ampoule neostigmine costs 4 rupees only. Just 12 rupee neostigmine can save a Cobra Bite patient. Now I have given the atropine plus 3 neostigmine equal to 1 ampoule. What is this ampoule? Anesthesiologists like Dr. Shobhan Sikdar, they usually use myopyrrolate. This is myopyrrolate. What is myopyrrolate? Here atropine is replaced by glycopyrrolate. If you give only neostigmine, there will be bradycardia, there will be muscarinic side effect of neostigmine. There will be profuse secretion of saliva. The patient is already in neuroparalysis. There will be paralysis of pharyngeal muscles. There will be deficiency in deglutition. So if you give only neostigmine, the patient may suffer from aspiration pneumonia. That's why always give atropine first, then neostigmine. It's also a mnemonic. We always tell give an injection. We never tell give atropine injection, then neostigmine injection. We always tell give an injection. If you have got really an injection, myopyrrolate contains equivalent of 5 milliliter of neostigmine, that is 2.5 milligram. In an adult, if you draw the full 5 ml and give intravenously, there will be no side effect because glycopyrrolate is there. So in case of Cobra Bite, an injection can save. Always give an injection before the sister has completed 10 vials of antivenom infusion. Now you see, sometimes the patient may be misled. The patient himself may be misled. He may mislead you. This man, 40-year-old man, came to Sonamukhi Rural Hospital of Bakuda district of West Bengal with a history of something, has given a thorn prick-like impression. He had stepped upon a bush of grasses. Something has pricked here. When he searched what has pricked here, he got a skeleton of a dead dog. So he thought that the tooth of a dead dog has done this injury. He ignored it. But after 3-4 hours, when there was swelling and pain, he came to hospital and told that I am suspecting of septic. And he had come only for one tetanus toxoid injection. But looking towards the swelling, Dr. Savitri Hasda had done 20 WBCT. 20 WBCT was not clotting. She immediately gave 20 vials of antivenom and transferred this patient to Bankura Medical College because the patient came after 3-4 hours. So there was violation of rule of 100. There was every chance of renal complication. If antivenom is given late to a viper bite patient, there is every chance of acute renal failure. মাইক গুলো বন্ধ রাখুন, আপনার মাইকটা মিউট রাখুন, আপনার শব্দে সবাই ডিস্টার্ব হচ্ছে। চণ্ডীতলা আপনাদের মাইক অন আছে, মাইকটা বন্ধ রাখুন, মাইকটা মিউট করুন। Now I am coming to the most mysterious part of snake bite, great neurotoxicity. Great bites are most mysterious one. Common Krait bite are almost 99% of common Krait bite. There will be no history of bite. The snakes bites in the deep midnight. They come to the open floor bed and bites in deep sleep of the patient. Patient may not notice. In 99% of cases, the patient may not notice that there has been any bite, but they may present to you. They may present to a hospital, usually with early morning pain abdomen. Early morning pain abdomen only. There may be early morning pain in the throat. Kindly keep your mic muted. Chunditala 1, your mic is open. Kindly mute your mic. Sound coming from your mic and disturbing us. Chunditala 1, kindly mute your mic. Ultimately, common Krait bite patients will show very slowly developing bilateral ptosis. Bilateral ptosis is the sure sign of neurotoxicity. Here, the patient is showing bilateral ptosis. The patient is unable to open his eyes. He is conscious. He is replying to the question asked by the treating doctor, but he is unable to open his eyes. Whenever you see bilateral ptosis in a patient, maybe the patient has come to your hospital for pain in throat, pain in joints, whole body pain, pain abdomen, whatever may be the presenting symptom. If you get bilateral ptosis, take it as granted that the patient has been bitten by a common Krait snake the previous night. But nobody knows what is the time gap between bite and bilateral ptosis. You see, this young boy of 15-year-old came to Kolkata Health Center in the early morning with bilateral ptosis along with pain abdomen. We call it a ptosis at 0 hours. Dr. Momita Mandal diagnosed this patient just looking towards his eyes. It was a case of pain abdomen, but Momita looked towards the eyes of the patient. There was sure signs of bilateral ptosis, and she infused antivenom, and this patient was cured. This patient, who is in the middle with tubes of ventilator, this 40-year-old person was diagnosed by this haggard at Calcutta National Medical College emergency 25 hours after a bite. There was no history of bite. They came 25 hours after bite with a CT scan plate and a diagnosis of Guillain-Barré syndrome by a specialist physician.
Yes.
But I could diagnose him to be a case of common Krait bite looking towards his eyes. This lady, 40-year-old lady, she was treated at Dhaniakhali Health Center of Hooghly district. She was admitted for pain abdomen. 3 doctors treated for pain abdomen. Then 4th doctor, Dr. Sheikh Rajiv, examined her and got bilateral ptosis. After 38 hours of admission, Rajiv infused antivenom and she was cured within 3 hours. So there is no certain period when you get ptosis. You may get ptosis at 0 hours, you may get ptosis at 38 hours also. This mystery of Krait are always challenging. You see, a page of a Bengali book published by Government of West Bengal in the year 2016. One case history is printed here. This is again a case of Hooghly district, Jangipara Health Center, and Dr. Shobhan Sikdar diagnosed the patient to be a case of common Krait bite by noticing bilateral ptosis, but patient party refused antivenom infusion. After 2.5 hours of argument, when the patient complained of respiratory distress, kindly mute your mics. Kindly mute your mics. We are being disturbed. So many people are being disturbed for your mic. Kindly mute your mic. See, there is a mic sign and click on it. The mic will be muted. Kindly mute your mic. Dr. Sikdar transferred this patient to a medical college of Kolkata, but unfortunately, his diagnosis was ignored by a junior doctor and the patient was kept in the general bed. Patient was not shifted to the ITU and died with
স্যার একটু দাঁড়াবে স্যার একটু ওয়েট করবেন এর কিছু একটা অনেকগুলো দেখছি মাইক কিন্তু অন করা আছে হোস্ট কে আছে ডেপুটি 2 স্যার ডক্টর চ্যাটার্জি একটু কথা বলুন আর এখানে চণ্ডীতলা 1 ব্লক এআইবি পিএসসি কে আছেন ওনাকে রিমুভ করুন ওনার মানে একবারে কাটছি জানেন না কিভাবে বারবার করে বলা হচ্ছে তবু কেন করতে না ইমিডিয়েটলি
মাইক গুলোকে মিউট করুন মাইক মিউট করা বুঝতে পারছেন না এই যে দেখুন এইখানে লাল লাল মাইকের রং দেখা যাচ্ছে কাটা আপনার ভিডিওটাকে অফ করে দেন
ভিডিও অফ করুন চণ্ডীতলা 1 ব্লক আপনার বাড়ির সমস্ত কিছু দেখা যাচ্ছে শুয়ে আছেন আপনার বাড়ির সবকিছু দেখা যাচ্ছে এটা কি হচ্ছে এটা
বসে দেখছেন আপনি এটা বুঝতে পারছেন না ভিডিওটাকে অফ করুন
কি হচ্ছে
ভিডিওটাকে অফ করুন
এই মিউট মাইক মিউট করা মানে তো আর শব্দ আমার পাবেনই নাকি
আপনি সব শব্দ শুনতে পাবেন আপনার শব্দ আমরা শুনতে পাবো না
আমাদের এখানে শব্দ পাচ্ছে না তো
হ্যাঁ আপনি পাবেন
আমি পাবো
প্রত্যেকের মাইক মিউট করুন শুধু চ্যারেটটা যেন থাকে অন আমরা প্রত্যেকে স্যারের এটা শুনছি আননেসেসারি আপনারা শুনতে না চাইলে আপনারা বেরিয়ে যান ওনারটা আমাদের জেলাতে এখন ভীষণ লাগবে যারা শুনতে চাইছেন না তারা প্লিজ শোনার দরকার নেই বেরিয়ে যান
ম্যাডাম অ্যাকচুয়ালি অনেকেই না এটাকে মিউট করাটা জানে না বোধহয় এই যে বারবার বলছি ওরা বুঝতেই পারছে না যে ওদেরকে মিউট করতে বলছি
না তাহলে এটা একটু রিমুভ করে দিলেই বেটার মানে যারা জানে না মিউট আনমিউট তাহলে তো মুশকিল তারা আমাদের তো এতে আসতে পারে এখানে
শোনা যাবে
সমস্ত শোনা যাচ্ছে ডক্টর হিমাদ্রি কুন্ডু প্রত্যেকটা শোনা যাচ্ছে
আপনার মাইক মিউট থাকলে আপনি শুনতে পাবেন আপনার চিন্তা নেই আপনার মাইক মিউট থাকলে আপনি শুনতে পাবেন I shall discuss elaborately later on this case of Dr. Shobhan Sikdar. Ultimately, this patient died at Medical College, Kolkata, and one senior doctor had done an inadvertent comment that it was a wrong diagnosis. So unfortunate. We forgot when we reach an upper position, when we reach a teaching position, we always forget that someday I was a junior doctor. You have made an inadvertent comment and total chaos came to this Jangipara Health Center and Shobhan Sikdar was very marginally saved by police of Jangipara Health Center. Never utter an inadvertent comment. Your junior brother, your student may do a wrong diagnosis in the periphery. But in this case, Dr. Sikdar was 100% correct in his diagnosis. After postmortem, this patient was declared as death due to neurotoxicity. This case of Shobhan Sikdar happened at Jangipara Health Center in the year 2014. In between, I have discussed this case in nearly 2,000 occasions, in nearly 2,000 sittings, that Krait-Bites are so mysterious. Krait-Bite, in case of Krait-Bite, there will be no bite mark. The patient may not notice any bite mark. The patient may not feel any pain. There will be no local sign. Ultimately, patient may come with pain, abdomen or sore throat. But this same sad thing happened in Dhannakudia Health Center of North 24 Parganas district. This girl came to Dhannakudia Health Center in the early morning with a history of loose motion just one time. Loose motion just one time. Then this girl became sick. Dr. Biswas diagnosed perfectly that there is bilateral ptosis and it's a case of common Krait-Bite, but her relatives strongly refused antivenom infusion. We failed. Each and everybody failed. Even the deputy 2 of that district got that patient party over the phone. He tried to counsel that patient party, but they had given written declaration that we are not allowing antivenomous infusion. Ultimately, this girl died. Though you need not identify a single snake to treat a snake bite case, we treat by scientific approach only. We see the sign and symptoms. We see sign and symptoms. Now I have uttered name of 3-4 snakes. This is your common Krait snake, a black color snake with slender white bands up to the end of its tail. Bands are up to the end of its tail. One snake is very much confusing with this one. This is called Kalach or Kala-Chiti. In some parts of Bengal, this is called Kala-Chiti. And this non-venomous snake is called only Chiti. You see, color may vary, but in Chiti, non-venomous wolf snake, there will be no band in the tail area. There will be no band in the tail area. But the snake which causes end of life, that is highly venomous, there is bands up to the end of the tail. Hooded snakes are, you see, spectacled cobra. In Bengali, this is called gokro. You mark behind the hood. And monocled cobra, there is a lotus sign behind the hood. Both monocled cobra and spectacled cobra are same, clinically same. And this is Russell's viper. This is an hemotoxic snake. In West Bengal, we get only Russell viper bites. Here, we don't get any saw-scaled viper. Saw-scaled viper is one of the big 4 snakes of India. The saw-scaled viper venom is used for preparation of polyvalent antivenom. But in West Bengal, there is no saw-scaled viper. Here, viper bite is only Russell's viper. These are the 4 killers of West Bengal: Russell's viper, common Krait, Gokro and KEUTE, spectacled cobra and monocled cobra. What are the take-home messages for the doctors? Snake bite is a life-saving emergency. Every doctor must treat a snake bite. Sometimes we have very unfortunate report that a gynae specialist was on duty in a district hospital and he refused to treat a case of Cobra Bite patient. He asked the patient party to bring a prescription from a physician. Ultimately, after 3 hours, when they could manage a prescription, the boy died. Each and every doctor must treat a snake bite. This Dr. Dayal Majumdar is an ophthalmologist. See, the ICMR Technical Advisory Committee is formed by the great Dr. Himmatrao Babaskar, then ophthalmologist Dayal Majumdar, and cardiologist Dr. J.C. Menon. We are treating snake bite and we are stamped as expert for snake bite management. Anesthesiologist of Assam, Dr. Surajit Giri, is now a world famous figure for managing snake bites. There is no chance of referral or second opinion in case of cobra bite. You have to treat it, you have to give an injection and antivenom. Don't forget rule of 100. You have to infuse 100 milliliter of antivenom within 100 minutes of bite. Always keep ready ambu bag ventilation in the emergency room. Sometimes patient may reach in total respiratory failure. You may not get enough time to send the patient to the ITU from the emergency room. And injections from cobra bites should be given at the emergency room. Now, what about the ligature? What about the removal of the ligature?
ডক্টর মজুমদার একটু ওয়েট করুন। হোস্ট কে আছেন একটু আমাকে কো-হোস্ট করে দিন তো। আমি ডিস্টারবেন্স গুলোকে
করতে পারেন। ডক্টর শোভন সিকদার বলছি, আমি এটা টেক কেয়ার করতে পারি।
হ্যাঁ, আমাকে একটু কো-হোস্ট করে দিতে বলুন তো। হোস্ট কে আছেন?
যাদের মাইক গুলো বন্ধ হচ্ছে না তাদেরকে রিমুভ করে দাও শোভন।
আমাকে হোস্ট করে দিচ্ছি, তাকে মিউট করে দিতে পারবো। হোস্ট বানিয়ে দিন আমাকে, করে দিন।
কতগুলো লোককে মিউট করা যায়? কতবার লোকজনকে মিউট করতে হচ্ছে? এ তো বড় মুশকিল দেখছি। এই যে মাইকটা চলছে, লোকের ডিস্টারবেন্স হচ্ছে, এরা বুঝতে পারছেন না।
আপনি মিউট অন করে দিন, তারপর মিউট হয়ে যাবে। আপনি নিজেকে আনমিউট করে আপনাকে বলতে হবে।
Never remove the ligature. Never remove the final ligature, the tourniquet in the emergency room. Always admit the patient and keep the patient in bed. Then start an IV fluid. Then only remove the final ligature. Never remove the final ligature in the emergency room. Always start with 10 vials of antivenom. Always start with 10 vials. In case of second viper only, in the other states of India, in the western India, in the middle of India, they start with 5 vials. But in West Bengal, we always start with 100 ml, that is 10 vials. Bite marks and broad snakes are of no use. Viper bites may lead to acute kidney injury, acute renal failure.
শুনতে পাচ্ছি না, বুঝতে পারছি না, এত চেঁচামেচি হচ্ছে, কিচ্ছু বুঝতে পারছি না।
যদি নিজে না করতে পারবেন,
so I am stopping here the presentation for doctors. Now I am looking towards the chat where some questions are there.
अभी चाहिए थोड़ा, जाएंगे नहीं, अभी रहेंगे।
How to understand whether it is hemotoxic or neurotoxic or myotoxic snake bite when patient just came to here? In case of hemotoxic bite, there will be abnormal bleeding. There will be abnormal bleeding, maybe from bite site, maybe from an injection site, maybe from any orifice. In case of doubt, you do a 20 WBCT. If the blood is not clotting, hemotoxic bite is diagnosed. But to understand a neurotoxic bite, cobra bite, there will be painful bite and progressive swelling. That is enough. You don't wait for any neurotoxic sign. It's a cobra bite, painful bite with progressive swelling, you diagnose it to be a case of cobra bite. In case of common Krait neurotoxicity is diagnosed only by looking bilateral ptosis.
इसमें आवाज नहीं है? क्यों?
One of my friend doctor gave 20 vials antivenom within 1 hour and injection max help. Gluconate at first advice. Is it okay? No, max help is not for injection. Max help is not for injection in case of snake bite. Max help is given to reduce the persistent swelling as compress, not injection. Max help is given for compress, not injection. Max help injection is given for preeclampsia, not in snake bite. Calcium gluconate is used sometimes in snake bite, but magnesium sulfide injection is never given. In case of your doubt, particularly in case of hemotoxic bite, Russell's viper bite, you can start with 20 vials of antivenom. So I am stopping here the presentation for doctors.
Sir, I have a question.
Ask it.
Hello.
Please, ask it.
Yeah. Sir, I have a question.
Your name, please, and where are you from?
Sir, I am Dr. Shubhinay Kumar Mistry, and I am attached with Ahmedpur Rural Hospital as a GDMO. And we often got these snake bites, and most of them are neurotoxics. And I just wonder how much neostigmine and atropine we will have to put after giving ASV.
Yes, I will make it detailed. It is clearly written over in our state protocol. I will detail it when I come back to the state protocol.
Certainly, sir. Actually, my doubt arose when one of our colleagues gave 42 ampule of atropine in a snakebite case. Is that necessary in some cases?
No. Maximum 2-3 ampule atropine and 2-3 repetition of neostigmine.
Yes, sir. That was what we taught in our academic tenure, but and also through the guideline. But I don't know whether he was gone through those academic paper or any guidelines. But he just gave 42 vials of atropine and more or less 16 vials of neostigmine.
If you have any doubt, or your friend or anybody have any doubt, just send me one WhatsApp message. Just
okay, sure, sir.
keep this WhatsApp number ready. 9433
1 second, sir. I'm just noting it down. 9433
104233.
104233.